Hello, everybody. I'm Dr. Deanna Minich. Welcome to this version of Personalized Lifestyle Pearls, PLPs. We like these interactions that we have with diverse practitioners from all over, shining the light on different conditions. And so today we have Amylee Amos.
Hello.
Welcome, Amylee.
Thank you. It's great to be here.
It's really great to have you. And for those of you who have signed on last week, you'll know that what Amylee is here to talk about is her work with Dr. Dale Bredesen. So the clinical work, some of their clinical trial publication work, and we're going to get into the 100 patient case studies and the different things that they've done in that regard. But, let's just first start by talking about brain health. And Amylee, what I've noticed from getting to know you a little bit and in our discussions is that you have some real advocacy for this whole area of brain health, cognition, memory, all of these facets. How did you develop that interest? I mean, why didn't it go down the path of cardiovascular disease or gut health? How did you get rooted into this whole area of research as it relates to brain health?
Yes, great question. Because of course, gut health, cardiovascular health, also very important. But specifically for me, cognitive health and dealing with neurodegenerative disease has, a special place in my heart because I have a family history of Alzheimer's. And after watching, and I think anyone would agree with me, anyone who has watched a family member suffer from Alzheimer's disease, it doesn't leave you. It doesn't. That's something that really sticks with you long term. And so for me, as I started my training and learning more about the various chronic diseases, I knew that I wanted to be part of helping people avoid or reverse the symptoms of cognitive decline. That was important on a personal level. So that's kind of how I got started in this. And then from there, it was, as we've talked about, when you're able to help someone who is dealing with dementia or Alzheimer's and they start recovering some of their cognitive abilities, there's no better feeling in the world. So I've been hooked ever since.
Wow, that sounds very promising in terms of being able to see that in action. Do you think that, based on your clinical experience, just when you see people, are there certain factors that can determine their success and eventual outcome in helping to remediate some of these cognitive deficits? Do you think that there are certain elements to be looking for clinically that will determine somebody's progression and trajectory?
Definitely. And I would say not maybe so much clinically in this aspect, but what I have found is that people who have a strong support system, so if the patient or client has people in their corner, whether that's a spouse or a partner or adult children, whoever it happens to be, that can sometimes make all of the difference because the interventions that we're going to be talking about are hard. They're hard even if you have, all of your cognitive, all cognitive capability. It's still hard to make these lifestyle changes for anyone. But if you put on top of that cognitive decline or memory loss, that's just a whole nother layer that makes it even more challenging. So I found when the individual who is suffering from dementia has people who are going to help and support and do it with them, that makes all the difference. So that's probably the biggest factor that I look for when I'm working with patients, making sure that they have that. And I've also found the more people, the better. So the people who have the entire family, the whole unit doing the interventions together, that really makes it easier, especially when it comes to things like family gatherings.
Yes, that is so true. And so how did you do that clinically? Did you have the whole family come in, or were there certain people designated to work with that individual when they would come in to see you? How did you do that exactly?
So in my office, I will have as many family members as want to come. So, it's normal practice that I'm running around trying to get extra chairs to kind of fit in the office because we have more and more people coming in, which is wonderful. I really feel like the more the merrier. And it's also important in my opinion, for the whole group, whoever's going to be involved, to understand why we're making those interventions, because that makes the compliance much easier. If everyone's on the same page with why each intervention is so important, they're able to follow through better.
Yeah, really good points. Now, by the way, Joanne Lombardi just signed on. She's saying, looking forward to this talk. Great. And we've got a number of viewers on, which is fabulous. And what we always like to do is to entertain questions. So I know that this is a hot topic for many of us because of personal reasons, or even professionally. Maybe we have patients, clients that we're seeing. So I'm going to be monitoring the post thread here, and any questions that you have for Amylee, please post them. What I do want to put on here before it gets too late is to put on this thread here, the article that we're going to be talking about. Hi, Robin. Glad to have you here. So, Amylee, one of the things that you just mentioned, and I know that everybody's signing on, whether it's for personal or professional reasons, everybody's going to want to know, what are these interventions and how do we go about them? So, you mentioned that some of them are hard and that it requires some additional support from family or other members. So please tell us more about what are these interventions that you're working with the Bredesen Protocol?
Sure. Well, while of course there are general interventions that most everyone does, they are individualized, I would say, by patient-to-patient basis. And that's a really important point. They're individualized because this Bredesen protocol is a multi-targeted approach that's trying to identify the root cause of the cognitive decline. And I think for a lot of people who are here, in the functional medicine community, that seems like, well, what else would we be doing? Of course, we're looking for the root cause, right? But,
yes, yeah. Absolutely.
Definitely. But, in the conventional medicine approach to Alzheimer's, up until this point, that hasn't been the case. So, we've addressed Alzheimer's disease as a disease because we have beta amyloid, the plaque accumulation in the brain. But the newest research shows us that beta amyloid is a protective response. It's an antimicrobial peptide. So knowing that, we need to work farther upstream and really identify what's going on that's causing these problems. And those are different for every person. And that's what the Bredesen protocol is really doing. We're trying to identify what are the root causes, because there's often many things. And we've identified, and Dale Bredesen has identified, trends. And so many people have similar metabolic contributors for their cognitive decline. And we've kind of identified those as the different subtypes, which we can also talk about. So I would say, back to your question, these interventions they vary based on the subtype and based on the individual contributors.
So let's get into those subtypes, because I'm already thinking, you mentioned the word metabolic, and I'm thinking there might be one that connects to glucose and insulin, which have a direct correlation to beta amyloid. Take us through those subtypes. How do we recognize those clinically?
Sure. So there are 6, and I would say in the clinical practice, I see certain ones very often. So type 1, we consider the inflammatory subtype, very common. Also very common in ApoE4 carriers, which we can talk more about the genetic aspect of this disease. But yeah. So inflammatory, it makes a lot of sense. Then we're dealing with anti-inflammatory therapeutics, basically. We're trying to reverse the inflammation. Type 2, we call the atrophic, so people who have suboptimal levels of certain vitamins, minerals, hormones, or they're requiring more brain-derived neurotrophic factor. And then back to what you were saying, the type 1.5, which is sort of a combination of those two, we consider the glycotoxic subtype, which we're dealing then with insulin resistance and issues with glycemic control. In regards to labs, we're seeing elevated fasting insulin, fasting blood glucose, elevated hemoglobin A1C, those types of that type of profile.
Okay. So that Would that be the three you said that there are 6.
There are. So those are probably the 3 I see the most often. There's also type 3 is a toxic, which is very challenging. That's probably the most challenging to treat clinically. And, toxic for a variety of reasons. So heavy metals, mold, pathogens can be various things. And then vascular would be type 4, and type 5 is traumatic.
There is so much on traumatic injury, just TBI, just brain injury in general. I was just listening to a TED Talk yesterday about this, about how so many people, whether in the school system, we often think of athletes, but there are so many other people with brain injuries. And so I would think, yes, if we look at each of these 5 with the 1.5, so 6 total, they each have like layers of root causes, right? The one I'm most intrigued with is the toxic one, because that's not one that's usually seen by many practitioners as an issue. It's still, to talk about environmental medicine and toxic burden and brain health is still kind of, people don't see those dots connecting straight away. I mean, we do in functional medicine and what we do, but I think most people don't. And so I think it's interesting to see these different subtypes. But you said that you work with the top 3. So inflammation, glycotoxicity, and atrophic. So looking at nutrient levels. Those are the more common ones for you?
Yeah, for whatever reason, that tends to be what I see the most in practice. Although with toxic, and I should specify, even though there are these subtypes and they're beautifully packaged, most people are combinations.
Yeah.
Most people do have a little bit of several, at least that's been my experience, is that not everyone fits just perfectly into just one of these subtypes. So just as an example, you might see someone who really has a strong glycotoxic profile, but they're also dealing with heavy metal toxicity. So are they one or the other? Well, they're probably a combination of types 1.5 and 3. And so we're working on all of those different issues to address their individual root causes.
Yeah, that makes sense. And I would think that no matter which path you took in to address that root cause, you're still creating a ripple effect. So if you just worked on insulin or even back to inflammation is so pivotal as a foundation, right? I often think of Dr. Bland's terminology, brain on fire. Maybe just talk with us a little bit about inflammation and the brain. Since that is subtype number 1, what are some common strategies that you would employ as a dietitian in practice to help those with inflammation? And I would think that most people with dementia have some degree of brain on fire or inflammatory diseases.
Definitely. So I would say in that case, my first thought would be start in the gut. So much research about the connection between the gut and the brain. And we know that inflammation in the gut alters neurogenesis. So we have to address the gut. And the gut, I think, is so actionable. There are so many different things that can be done, that should be done. So that's probably where I would get started in terms of inflammation. And then, in keeping with that, modifying the diet, our diet can be either the most anti-inflammatory treatment modality or the most inflammatory thing that we can do. So we choose with every forkful. Are we contributing to an inflammatory problem, or are we actively reversing that inflammation? So really addressing from a nutritional standpoint, and my first thought in terms of how are we going to have less inflammation in the gut is the color, which we were talking about, getting in all of those different colors. We're going to achieve huge benefit just from that. So that's probably where I would start.
That sounds great. And what would be some of the foods that you'd want them to avoid? So if you want them to bring in colorful, whole plant-based foods to help on the anti-inflammatory side, what are some of the biggest inflammatory food offenders that you tend to see in people with cognitive impairment?
Definitely the refined carbohydrates, all of the added sugar. So I really think we don't need to worry as much about sugar that's prepackaged in our plant foods, that's the good sugar we can have. But all of the sugars that are added to things and that are often added to foods that we would consider health foods. Yeah. That's so tricky, I think, for the consumer who's trying to do the right thing. Just quick example, kombucha is so popular and so great, great way to be drinking your probiotics, helping your gut, but so often just loaded with sugar. Not all, but it's really important to make sure we're not contributing to inflammation as we're trying to make a healthful choice. So really, I would say, all of the trans fats, the refined carbohydrates, the added sugars, those would probably be where I would start. And then depending on someone's, their individual lab workup, we would look for other things. So for some people, it's really reducing red meat and, bringing that down to smaller portions and really quality sources. For other people, reducing the dairy, getting that down in the diet as much as possible. It depends. So we take it on an individual basis. And then just like with everything in a functional medicine approach, working with the patient on where do you want to start. I found that that's really helpful. Meeting someone where they're at and allowing them to be the one who chooses out of all of these different things that we can do to help have an impact. Where would you like to start? And I found in terms of compliance, that's very helpful.
That's a great clinical strategy because then you're just going to have more compliance in the long run.
Yeah.
I'm kind of curious. So you mentioned reducing red meat. How does Dr. Bredesen and how do you feel about employing something like the ketogenic approach for brain health? Are there certain ways to personalize that?
Definitely. And, in fact, we're using a mildly ketogenic diet very often, specifically the ApoE4 carriers. The research shows that E4 carriers can have impaired cerebral glucose utilization actually as young as age 30, which is, I think, very surprising. And so if we imagine the decades of, a lack of cellular energy and one way of speaking, of course, we're going to have fatigue in the brain. So, the just mild nutritional ketosis is able to bypass those impaired pathways and fuel the brain. But there are many ways to achieve mild ketosis. So my approach in general is a plant-based approach, and I found that you absolutely can achieve mild ketosis, just the amount that we need. And our clients are measuring their beta hydroxybutyrate, so they're certain that they're in this range, and we're able to do it on a predominantly plant-based diet. And from Dr. Bredesen, just working with him and what he says, that doesn't necessarily need to mean vegan or vegetarian. That's just plant-based. So, yeah. So condiments, he said he would say use meats as a condiment rather than the star of the plate, which I think is a really great way of thinking about it. And it allows it, to work for more people that way, a little bit less restrictive, just changing the way we think about portions on the plate.
Yeah, that's excellent. And so so what I'm getting is that the food part of this is really personalized, but with a focus on plants. And then how do you then stage the therapeutic protocol in such a way to start bringing in targeted nutrients or dietary supplements or even powders that are a bit more nutrient dense for people who aren't accustomed to that, who need a bit more? So how do you then graduate from food as the foundation, I'm assuming, because you and I come from that same path of thinking food first, right? That's so essential. And then how do you move into the targeted nutrients? How is that determined?
So it's determined through the lab work. So normally I always, start with food. That's always our first go-to. And in general, my kind of thought on that is we're priming the body first, just getting a foundation, a nice, healthy foundation. And we achieve that through nutrition, just through our diet. And then from there, based on the labs, certainly supplements are often needed. And I would say people have very different views on supplements. Some people want to get started with supplements right away, and they think that's going to be the answer. And it's never one thing; it's always multiple things. If only it were that easy, just to take, one thing or change one thing in your diet and have, full reversal of your symptoms. But in most people, it's very helpful. And, we're also dealing with a variety of abilities in terms of taking supplements. Some people, especially in an older adult clientele, some people have a very hard time taking multiple supplements. So we have to be choosy in that case. And again, looking at the individual contributors, what is going to be the most beneficial. And then from there, we're often wrong as well. So that's why retesting the labs becomes so important, because you might think a specific supplement or a few tweaks to a nutrition plan is really going to have a massive difference. And then if you're retesting the labs and have found it didn't have the effect we wanted, we need to reassess and, change our approach. And that's often the case.
And I would think, too, that you're looking at symptoms and the labs, right? Because the labs being one moment in time, kind of looking at symptomatic relief. Are they improving in their cognition, or how is their mood changing? And so kind of looking at all of that, right?
Absolutely. And in fact, from my experience working with patients and their families, the family only cares about all of the subjective. They're really, when they have found that their person is now coming back and has more energy and they're more alert, or they're not having the memory issues, that's what they're living for. And that's what they are thriving on. So as the clinician, we want to see it in the laboratory data as well. We want to see it in their mini mental status exam, or however we're tracking their cognition objectively. But for the families, they're really just interested in seeing the improvements in their loved one.
Yes. And that's why, again, that team-focused approach, having people go through this whole process collectively so that everybody's benefiting and everybody's really aware of what is being done and what are the changes. We do have a question here about intermittent fasting. When I think of intermittent fasting, I tend to think of, that's kind of a generic term for many different ways to restrict food, right? And typically we think of time-restricted feeding, maybe an 8-hour window per day. But is there a role for that within your practice? Is that something that you talk with any number of people with cognitive impairment about?
Absolutely. And again, that's something that's individualized based on a number of different factors. But the research does suggest that people who carry ApoE4 are better adapted to longer fasts. So we do have, for the most part, people who are carrying ApoE4, we extend an overnight fast more so than someone who does not. So anywhere, I would say, from 12 to 16 hours in terms of an overnight fast is often used. But, it's unfortunately not quite as black and white as that. It's a bit more nuanced, because I also see in practice a lot of people who struggle with weight. And what I mean by that is they lose too much weight when we're making these modifications to their diet, and also imposing these, a time-restricted eating kind of protocol for them. So it depends. We obviously, especially in an older adult population, we don't want people to lose too much weight. So sometimes we do have to sacrifice the length of that overnight fast to extend the window of eating.
So then what about on the flip side and looking at more physical activities? So if more food has to be taken in, but ensuring that there is proper oxidation, burning of that fuel, I'm sure that you bring in physical activity as one of the many facets of lifestyle change into your protocol as well. Absolutely.
And again, back to the research, there's no way we could avoid it based on the incredible research. It would be so, wrong to not discuss that with every single person who's dealing with this. And I would say, there's first of all, incredible research about aerobic exercise and hippocampal volume. So, definitely getting in the aerobic activity, but also certainly the resistance training, mobility and balance. All of those are really key for people who are struggling with cognition, and making sure that they have all of those aspects and done in a way that's safe for them, that's challenging for them, but also safe. And again, that has to be individualized.
Yeah, that's an excellent point. We do have a question from Marta, who's asking, should ApoE4 carriers avoid saturated fat? I know that there's some discussion about that in a variety of different circles, and maybe you can address that. You've already been talking. Why don't you just talk a bit about ApoE4, maybe answering this question, and then how important it is to know whether or not you have that genotype, and then some diet and lifestyle strategies for it, if you do, the different types.
Sure. So ApoE4, it's a genetic variant. We all have 2 copies of ApoE. We either have ApoE 2, 3, or 4. So we get 1 from each parent. So it's possible that you have 2 copies of ApoE4, and that would give you the strongest genetic risk for Alzheimer's disease. That risk would go down if you just have 1 copy of ApoE4, and even less if you have no copies of ApoE4. But I should point out, as we're having this conversation, that this is genetic risk, so it's not diagnostic. Even with 2 copies of ApoE4, this is not diagnostic. Okay. And what we know, we've used information, there's been great research done about ApoE4. We know that that's the oldest genetic variant. So our early human ancestors, they were all ApoE4 carriers. And it was really beneficial for them because it helped them launch a strong inflammatory response, which was great as you're fighting your food and you're fighting with each other, running around barefoot. That was really helpful that they could do that. Not helpful anymore, right? We're not doing any of that anymore. So now that's not as helpful. But so knowing that, that they're better adapted for things like fasting, that they're able to launch these inflammatory responses, it helps us optimize, or maybe that's not quite the right word. It helps us maybe we're exploiting that knowledge and getting the most out of that genetic variant, all of the good that it can bring, and depressing any of the problems that can arise because of it. In terms of the saturated fat, which is a hot topic, again, especially because we know that mild ketosis can be beneficial for ApoE4 carriers, and generally the easiest way to achieve mild ketosis, or ketosis for that matter, would be through MCT oil, which is a saturated fat, and lots of other high-fat foods, which tend to be saturated fat foods. Clinically speaking, I have seen that there tends to be a lipid spike. So we see cholesterol go up, triglycerides go up when ApoE4 carriers are on a high saturated fat diet. So it's not generally what I recommend. We do use MCT oil in my practice. We use it as a transient intervention. So we help really, our goal is to help them achieve metabolic flexibility. So just the ability to fluctuate between a glucose-based metabolism and a lipid-based metabolism. That's really the goal, not high levels of ketosis all day, every day. And a little bit of MCT oil used therapeutically can be helpful in kind of getting over that hump and to the point where the body is able to transition between those two. And then we taper off and we push the monounsaturated fats.
And so what would be considered high dietary saturated fat? What percentage of energy or calories do you see as being high, as kind of like the cutoff?
So, gosh, that's a good question. I think many people would have very different answers. And when I'm working with clients, I don't generally give numbers like that. I talk more in terms of foods, just because I think for most people, it's easier to think in terms of foods. So most fats, I like to think about, where are we getting our fats from? And so we're doing a lot of olives, olive oil, avocados, nuts, seeds, fatty fish that's low mercury. We use that SMASH fish acronym, salmon, mackerel, anchovies, sardines, and herring. So we're trying to get mostly mono and polyunsaturated fats from those types of sources. And then small amounts, first of all, as we know, most things are a blend anyway. Most things are, the fatty acid profiles have, they're a mixture, which is perfectly acceptable. But basically, my takeaway is if we're doing mostly plant-based sources, you're not getting as much saturated fat. So it kind of takes us back into plants first.
Good. Great. We do have another question here from Eric. What is your clinical approach to client accountability? We can measure labs, we can recommend dietary and lifestyle changes. If clients aren't willing to commit to behavior changes, the results will not be optimal. So how do you measure accountability, and what is your approach to counseling the client struggling with behavioral modification? I think that this is the question, right? I mean, I think no matter what area of health and healing we're talking about, we're always talking about behavioral modification. Do you have anything up your sleeve as to what works and what you have found keeps people on track?
Right. Well, I mean, yeah, it's a fantastic question. And I'd say kind of goes back to what we were saying before. I think in my experience, the best way to hold someone accountable is for their family to hold them accountable. Because when someone's in your office, I mean, they can tell you anything. You know, they're going to hopefully be telling you the truth, but they can tell you anything. You're not there with them day and night. You're not there prepping their meals and seeing what they've eaten. The family is. They are there. The spouse, the partner, the adult children, whoever it happens to be, they're there all of the time. So if that person or those people are wanting to hold the client accountable, that's when I've found it actually works. When someone's on their own, I mean, it's challenging, especially again for someone who has memory issues, who might not remember what they're supposed to be doing. I also find that, you know, and something that's helpful is working with a client to get the foods that, you know, are not part of your nutrition plan out of the house and fill the house with foods that are. There should always be foods that someone can eat, but if other things happen to be in the cabinets, again, even more so with someone with memory issues, there's no telling what's going to happen. Someone might not remember that that's not for them, it's for someone else, and before you know it, they've deviated from the plan.
Yeah, out of sight, out of mind. And so if it's not in the kitchen, it won't be in the mouth, you know? So I think that that's a really good avoidance first approach. Eric and Amylee, one of the things that I like too is taking photos. So if people can take photographs of the inside of the refrigerator, just, you know, because not many people are going to switch that around, or their cupboards or their plates. I feel like, you know, we can use the smartphone to our advantage. And most people, even if it's the family members, maybe taking pictures and kind of showing like, hey, what do you think? This is what I have in the fridge. This is what my salad looks like. And I remember doing that years ago with somebody asking for a picture of her salad and then seeing it was all iceberg lettuce and cherry tomatoes. Right. So I think that we can gain so much by actually seeing what people are translating to us so that we can be sure that we're on the same page.
I love that. I'm going to have to use that. And I love anything where you're using technology to, you know, help make the practice even better. That's fabulous.
Well, yeah, and that's an easy one, at least. It's no app or anything. It's just, you know, everybody can take pictures on their phone, even the family members. So that can be helpful. Definitely. So in our closing comments here, we're going a little bit over time, but we've got a lot of interest here. Talk a little bit about this. You know, one of the things I like about you and Dr. Bredesen both is that you're both into science and evidence, and that is how a lot of the clinical protocols and everything that you're doing has been created. And I really like what you're saying about how, you know, just looking at the ApoE4 research and that got brought into your protocol. So now you have a study, and I've posted the link on this thread for everybody. It was a 100-person case report series, and it was published in the Journal of Alzheimer's Disease and Parkinsonism. Mm-hmm. So talk a little bit about that and your experience. You're one of the authors on the paper. There were a number of clinicians that had all used the protocol. What did you find from this 100-person study?
Yes. Well, I would say, first of all, you know, 100 different people who had really varying degrees of cognitive decline, which I think is wonderful, that we're showing that people who were just starting to see signs and whose, you know, tests showed that they were just on the verge of starting to have cognitive issues, they had improvement, and people who had a MoCA score as low as 0. So these are people with full-blown cognitive decline, Alzheimer's disease, and they showed improvement as well. But there's also varying levels of improvement. And I would say that's very indicative of what I'm seeing in practice. Some people have huge improvement and it happens quickly. Other people, it's slow and it's mild improvement. So it's nice that the paper really demonstrates that. I think that's a real asset. And then I think the other thing that's the main takeaway from this paper that we published is that all of these results are highly achievable. And that's shown because we have people in 15 different clinical sites that are showing that they had the same results.
That's fantastic. And again, that really speaks to the power of personalized protocols and how if a protocol can be personalized to the patient, no matter what clinic, and still get the same results, I think that speaks to the robustness of the clinical protocol itself and how much it has staying power, no matter who is implementing. Yeah. There is another. It seems like as we close here, there is a number of interest in pharmaceuticals and looking at things like proton pump inhibitors, looking at, there's a question about SSRIs. Mm-hmm. How do you work with medications? Maybe we take this as a general categorical type of question. So how do you work with medications, pharmaceuticals, vis-a-vis a lot of these other things like food and dietary supplements, because there can be drug-nutrient interactions. And many of these patients are on a number of different drugs, whether for the gut or for their brain, maybe even for cardiovascular indications. So how do you navigate that space a bit?
Mm-hmm. So first of all, I would say I highly encourage everyone that I work with as a dietitian, nutritionist, to also see a functional medicine trained physician, an MD or an ND, or someone who's able to, someone who has an expertise in the pharmaceuticals. I do think that is important because, again, we want to be careful with the supplements. Some of these interactions are, very well established, and we know exactly what to look for, and we can be very careful about it. And sometimes people are on pharmaceuticals that personally I'm not familiar with, in which case it's, for me as a clinician, very important to make sure that they're checking with their primary care physician and making sure that anything that we would recommend as part of their protocol is not going to have an interaction. The research is just booming on a lot of these pharmaceuticals that you mentioned, like the PPIs. I think it's important for anyone who's worried about that to make sure that they see practitioners who are well-versed in that research, and I think, luckily many practitioners are now, but a lot of it is on the newer side. So that's an important discussion to have with your primary care.
Absolutely. And a lot of these different drugs could create nutrient insufficiencies or deficiencies that can ultimately lead to a lot of these mood and memory imbalances as well. I think about PPIs, vitamin B12, so many different things to be thinking about here. So great questions, everybody. It looks like we've had such great interaction, a lot of hellos from many different places, and so many great questions. And so what I'm thinking is let's keep the questions going on this thread, and Amylee and I will continue to check in and see what questions might come up at a different time if you're watching this at a later date and time. But this is a fabulous talk with you, Amylee, because you have been in the trenches now for some time. You've been working with Dr. Bredesen for the past 5 years, seeing patients, working with the protocol, and so you're a wealth of knowledge. So lovely to have you here and to be able to tap into your wisdom.
Yes, so great to talk about this. Thank you so much for having me.
We can definitely tell that you're very passionate, which is great. Keep the fire alive, and we look forward to hearing more from you in the future.
Thank you.
Thank you.